Positive approaches to providing support. Welcome to Module 3, Policy and Recording. I'm Amelia Coleshaw and I'll be going through this session with you today. This is session 3 of 4 blended learning modules. It's a recording of a presentation with a workbook for you to complete. The workbook will not be marked, it's to aid your learning and for your own notes. During the presentation, you'll be asked to pause the recording and fill out sections of the workbook. You can do this electronically or print it out. Once you've completed the module, you can discuss the workbook with your manager in your next supervision. You will have already completed Module 1, Understanding Behaviour, and Module 2, Positive Behaviour Support. This is Module 3, and then when you've completed it, you'll be able to do Module 4, Health and Safety. When you've completed all of them, you may have a live interactive session on Microsoft Teams as part of a group. And depending on which service you work in, you may also have a short face-to-face session to learn and practice any physical techniques. To get the most out of the session, break it up. Online learning can be tiring. Take breaks when you need to. You can pause the session anytime. Don't be a passive participant. There are activities to complete throughout the course which will promote a deeper level of learning and will be more engaging. Take notes if you find it helpful. This will also foster engagement and promote a deeper level of learning. Repeat. If you don't understand something, please watch it again. Ask. If you're unsure about anything, please check with your manager or a colleague, or you can email me on the internal email system. The aims of the session today are to introduce you to your restrictive intervention policy. We'll be looking at the legal framework around working with people where you might need restrictive interventions or restrictive practices, and being able to tell the difference between a restrictive practice, a restrictive intervention, or a deprivation of liberty. State the 4 categories of restrictive intervention and understand what you need to record and how and where to record it. And just to recap, the curriculum or the content of this training is taken from ProAct Skipper UK, a positive range of options to avoid crisis and use therapy, strategies for crisis intervention and prevention. The content of this training and any physical techniques you may learn comply with the Restraint Reduction Network Training Standards 2019 and are based on guidance from the Department of Health, Positive and Proactive Care. And just a reminder, you'll have looked at this a lot in the last session, Positive Behaviour Support, that most of the time we're using a proactive strategy with people. Sometimes we find that people may be showing signs of upset or distress, and we then may use an active strategy to try and de-escalate the situation before it goes any further, and often that works really well. And on the rare occasion when it doesn't, we may have to go into using a reactive strategy in order to keep everybody safe. You may be familiar with the Restrictive Interventions policy, and if you're not, it might be worth having a look sometime just to know where you can find it and know what it covers. It is on the intranet, and it gives a really good framework for helping us think about when it may be lawful and reasonable to apply a physical intervention or a restrictive intervention, because we know that some people with some behaviours may need restrictions in place in order to keep them safe and enable them to access activities safely and go out in the community safely. It's informed by various acts of law, for example, the Human Rights Act and the Mental Capacity Act, both of which you'll be familiar with, and again the Positive and Proactive Care guidance from the Department of Health. And part of the policy is a form that we use to record the use of any planned or unplanned physical intervention. So it's all in one place and all links together quite well. When we're recording the use of a restrictive intervention, we need to say what type of intervention it is, because you'll see there are different categories of restrictive intervention. And also, if it's a physical intervention, which would be a proact skip technique, they all have their own names and a set way of being applied, and typically that would be a 2-person touch support or a 2-person arm support. We also have to record why we might need to use it at times, how often we might be using it, and when it's going to be reviewed. And then within the recording form, there's also space to show how we've applied the principles of the Mental Capacity Act in terms of trying to involve the person in understanding why we may sometimes need to use a restrictive intervention and trying to ascertain how they may feel about that. And views of others involved, it's always really useful here if you can get the views of someone outside of the service, for example, a parent or family carer, and they should be signed off by the service manager. And there's an example in your workbook that's taken directly from the policy, so if you want to pause the recording here and have a look, it starts on page 2, so you'll get an idea of what you'd need to complete on that form. Take a few minutes to have a look. The definitions that we're working with that we'll look at a bit more closely are a restrictive practice, a restrictive intervention, and a deprivation of liberty, which is otherwise known as DOLS. And at some point soon, that's going to change to the Liberty Protection Safeguards, or LPS, but at the moment, we're still working with DOLS. It's important to know the difference between these different definitions because they involve different levels of restriction. Within the scope of your restrictive intervention policy, we only need to use it to record restrictive interventions. So anything that we consider a restrictive practice is recorded elsewhere, and that's often on the service statement, and anything that's a deprivation of liberty is applied for and recorded in a completely different way, and there's a whole process around that you may be aware of. So with your policy, we are only concerned with recording restrictive interventions. A restrictive practice is something you have in place which may stop someone doing something they want to do, or which may make them do something they don't want to do. So a restrictive practice is at the lower end of the level of restriction and tends to be in place all the time regardless of what's going on. An example of this may be somebody in a supported living setting where the food cupboards in the kitchen are locked because someone who lives in the setting will frequently take food and use food from other people's cupboards. So the practice in place was to lock all the cupboards, and some people had their own key and staff looked after other people's keys. But that would be a restrictive practice, and a good reason for doing it. It's approved and it's okay, and it makes sure that people don't get into other people's cupboards and eat or take their food. A restrictive intervention is where there's a deliberate act on the part of a person that restricts an individual's movement, liberty, or freedom to act independently. And again, it will be an approved and agreed way of working, and the reason you'll be using a restrictive intervention is in order to take immediate control of a dangerous situation where there's a real possibility of harm to the person or others if no action is taken, and to end or reduce significantly the danger to the person or others, and contain or limit the person's freedom for no longer than is necessary. So you may think of an example where you have to intervene and use an intervention to stop someone from running out into the road in front of a bus, because if you don't do that, the consequences will be much worse. And with any kind of restrictive intervention, we always use the least amount of restriction for the shortest amount of time, and that's reflected in the law and the guidance. Within the guidance, there are 4 different categories of restrictive intervention: physical restraint, mechanical restraint, chemical restraint, and seclusion. So let's just have a look at those in a bit more detail. Physical restraint is where we use any direct physical contact where we're intending to prevent, restrict or subdue movement of the body or part of the body of another person. So the example I just gave you, you may need to use a plyox skip technique to stop someone from running out in front of a bus when they'd never done it before and it wasn't planned and you hadn't anticipated it. So any of these kind of restrictive interventions tend to be things that are done in the moment as a response or reaction to what's going on, with an intention to keep people safe and limit the likelihood of harm or injury, and where you think, well, actually, if I don't intervene, there's going to be a worse consequence. So it balances out with duty of care as well. Another example might be if you work with someone who has self-injurious behaviour, it may be that within their guidelines there might be things you do for a certain amount of time if they are injuring themselves in order to reduce the level of injury they may sustain. Mechanical restraint refers to using a device to prevent, restrict or subdue movement of someone's body or part of for the primary purpose of behavioural control. Now, I don't think in your services this really goes on much at all. The only example we've ever really had around this was the example of a young man who, to access the day service, needed a 5-point harness on the minibus because it was the only way he could travel safely. Because of his behaviour, he would remove the seat belt and get up and move around and make it risky for himself and others. And again, that was an agreed and approved way of working. It was recorded, and that meant he was able to come into the service every day and use the transport safely. Chemical restraint refers to prescribed medication that's administered to control or subdue disturbed or violent behaviour. So examples of that are any of you who work with people where they might have PRN or as required medication, and you'll be using it generally when someone's clearly escalating, and it will be used in order to try and keep them calm or de-escalate their level of arousal so that they're less likely maybe to have a crisis situation and cause harm. And if you do work with people like that, you'll have very clear guidance as to when you administer that medication. And again, it's an agreed and approved way of working and aims to keep people safe and reduce risks. The last category is seclusion, which is supervised confinement and isolation of a person away from other people in an area they're prevented from leaving. Now, again, this is not really something that's in practice in services, and in the guidance it says that only people who are detained under section of the Mental Health Act may be considered for seclusion. So it doesn't really apply in your service, and it's not part of the policy. The other 3 are. So when you look at that recording form, it says what type of restrictive intervention are you using, physical, mechanical or chemical. But it doesn't include this one because that wouldn't be happening anyway. So just to recap, the 4 categories of restrictive intervention: physical restraint, mechanical restraint, chemical restraint and seclusion. You're probably familiar with the term deprivation of liberty, and you may work in a setting where at times people are deprived of their liberty, and that's needed to be agreed and approved and authorised. So deprivation of liberty generally applies to residential and hospital settings and some supported living settings, generally anywhere where that's a 24/7 care and support provision. And it's a higher level of restraint, so the restriction or the restraint is used pretty much all the time or for long periods of time, and there are quite a few restrictions in place. So it might be that people are closely monitored and observed, staff always know where they are, maybe limited from accessing different parts of the building, and there might be limited in terms of what they can do in their activities, and generally not free to leave unaccompanied should they choose to do so. So if someone's in a 24/7 provision and is under a deprivation of liberty safeguard and wants to leave, the safeguard means that staff are able to stop them from leaving on the basis that it's not safe for them to do so on their own. So yeah, some of you may be familiar with that. So just a recap of what falls within your restrictive intervention policy in terms of reporting and recording is just restrictive interventions and not restrictive practices or deprivations of liberty. So a restrictive practice would tend to be recorded on the service statement of purpose, because often they'll affect everybody. If it's a key padlock on a door, they'll affect everybody coming into the service. Restrictive interventions use the form that you've looked at in your workbook, and as I said, that incorporates the bits you need to show that we followed the Mental Capacity Act Code of Practice. And if it's a deprivation of liberty, there's another whole process that you would use to get that agreed and authorised. Okay, I'd like you to pause the recording here and have a look at page 7 of your workbook. And I think there are 8 different little scenarios, and just asking you to think about, is it a restrictive practice, a restrictive intervention, a deprivation of liberty, or none of the above? And on page 8, I've given you just a little recap to help you remember the difference between those definitions, and remembering that any restrictive practice, intervention or deprivation of liberty is an agreed and approved way of working. So yeah, see how you get on with that. So when might it be reasonable for us to use a restrictive intervention? You can use one in order to control a dangerous situation, end or reduce danger, and as we said earlier, anything you do must limit the person's freedom for no longer than is necessary. So the least amount of restriction for the shortest amount of time. And if we use the least amount of restriction for the shortest amount of time, and also if the intervention was already employed or as part of someone's positive behaviour support plan and is planned and agreed and approved, then you should feel confident about your practice and what you're doing and why. And one of the ways to think about it is regarding our duty of care. And sometimes in a potentially dangerous situation, if we don't intervene, we could be failing in our duty of care. So duty of care is the responsibility we have to protect people from harm, and that means we have to take reasonable care to avoid doing things or not doing things that could cause harm to another person. So if you're in a situation where something's happened unexpectedly and you're thinking, oh, what should I do? Can I, can't I? Generally, if the consequences of not intervening are worse, then you will be working within your duty of care if you intervened. When looking at what's reasonable in terms of duty of care, you might think, well, what would someone else have done in my situation with a similar level of training and experience to me? What would someone with some expertise or specialist knowledge in this area of practice think or recommend or advise? What were the prevailing circumstances? Have we done everything we could to de-escalate the situation or manage it differently? And what were the foreseeable associated risks? If we didn't do something, what would the consequences have been? We're going to have a quick recap of the Mental Capacity Act now, which you should be familiar with, but it does play a key role in working with people with restrictive interventions, especially in the recording. So we know there are 5 key principles. The first one being we must assume that someone has capacity to make a decision unless we can demonstrate otherwise. We must do everything we can to give the information to the person in a way they can understand. And sometimes often it's okay for people to make a decision that other people may think is unwise. So those first 3 relate to people with capacity. And if someone's judged to lack capacity, then any decision carried out on their behalf must be in their best interests and also must be the less restrictive option. So how do we make judgments about someone's capacity? We presume they've got capacity to make a decision. We do everything we can to give them the information in a way they can understand. What we then have to do is make a judgment as to whether or not they have understood that information. Can they retain the information long enough to weigh up the information in their decision making, and can they communicate their decision back to you? Now this is really tricky when you're working with people with a learning disability, because we're never that sure or confident about how much we think people have understood. And you'll have different ways of checking this by asking them in different ways, using different questions, getting different people to have the conversation with them in different environments. And often you'll be working with people where there's communication differences, or people don't use words or language. So then it's really hard to know. And sometimes when you're supporting people like that, the best thing we can go on is observing their responses or reactions when something happens, to give us an idea of how they feel about it and if they're accepting it or rejecting it. And sometimes in these situations that's really all you can go on. You can stop the recording here and look at, I think it's about 6 minutes, but it's a little animation about the Mental Capacity Act, which is just a good reminder of it and how it applies to people and what we need to be thinking about. So thinking about capacity and consent in the context of supporting someone who may need to have a restrictive intervention applied at times. See if there's someone you can think of that you support who this relates to, and think about that person as you know them and their level of communication and how you communicate with them. And think about your filling out, or you're completing a restrictive intervention form to get an intervention set up, because you know you may need to start using it with the person. How would you involve the person in this and ascertain how they feel about it? So think about how you would be communicating with them, trying to explain to them that sometimes in these situations we may need to use this. You know, think about the communication tools the person uses, who it is that's trying to give them the information. And then also, how would you check how much you think they've understood and retained, or how they feel about having a physical intervention applied? Again, especially maybe people that don't use words, and we have to go on observations of their behaviour. So I'd like you to take a couple of minutes to think about that. And then when you've done it, if you pause the recording, and if you look on page 9 of your workbook, there's an example form that covers these aspects of recording and hopefully will make a bit more sense to you when you look at it. Okay, just before we look at the Care Act, I just wanted to recap on the example of the restrictive intervention form for Julie that you've just looked at, and just to point out how, you know, the workers used her communication tools with her. Good to try and have a conversation with her about it when it was a normal time of a normal day, and she, you know, hopefully was receptive to that. They showed her what the intervention looked like on each other so she could see it being used, and following that they asked her permission to show her what it would feel like if they had to use it with her, and she consented to that. But at the same time, they weren't sure how she would feel about it being used, and all they can really do is say that if it does have to be used in a real situation, you know, they'll observe her responses and reactions, and it may be that it works fine and she doesn't object to it, which would be great, or it may be that, you know, she does object, and then that's a bit different. So it's really just trying to write down and record. We call it showing your workings, writing down and recording what you think and why you think it, even if you're not really sure of the outcome or you can't be really clear one way or the other. Okay, that was around the Mental Capacity Act. We're now looking at some other acts of law that are relevant here. So you probably have heard of the Care Act that came in 2014, which kind of superseded and absorbed lots of different acts of law, and applies to us as a local authority. So we have a duty to assess people with care and support needs, and some of that is around assessing their challenging behaviours and how that would factor into the kind of services they may receive or be eligible to receive. We also have a duty to assess risks, and you'll be quite familiar with risk assessments. I'm sure you've got many in place for different things in your service, and that's a you know, big and important responsibility that we have. We also have a duty to provide enough budget to meet people's eligible care and support needs, and that can be contentious sometimes when we're all working with less and trying to do the best we can with what we've got. Duty to promote people's well-being and preventing needs from escalating. And you'll remember, if we come back to that kind of pie chart and the 70% proactive strategies we use all the time, that's very much around promoting people's well-being and quality of life. And we also have a duty to assess and support informal carers, and you'll be familiar with people's carers and what some of the challenges there are for them in their caring role, and the impact that having someone with a learning disability in the family or a family home can have on the whole household and siblings. And so yeah, duty to assess and support carers too. And something else the Care Act brought in was what's known as the duty of candor, which you may be familiar with. There is a duty of candor policy which you can find on the intranet, and it applies to all providers, so NHS trusts, foundation trusts and health authorities firstly, and then regulated providers of social care from 2015. So those of you working in a regulated service that are subject to inspection from CQC should be aware of this. The duty of candor is very much about having a culture in place and a process in place for being open and honest with people when something goes wrong. And it came about because of the amount of scandals there have been, or situations where people have come to harm or died and it had been brushed under the carpet and attempted to be covered up. So there's a big drive to be much more open and transparent when something goes wrong or someone is caused harm. And you do have a policy around that, which I'm sure your manager will be familiar with, and you may know about too. And the duty says that we must let the person or their family know when harm has occurred and be really clear and open about it and apologise and show remorse. So apologising doesn't necessarily mean taking complete responsibility, but it does mean showing remorse that someone has come to harm, and agree with that person or their family what further actions you're going to take, and then write to them or their family to let them know what's happened and anything else you're going to do about it. The Human Rights Act we mentioned earlier, there are two parts really that relate to this. So Article 3, the prohibition of torture, and that nobody should be subjected to treatment or punishment which is inhuman or degrading. And that's why we use PROACT SKIP, and that's why we work within the training standards that we do, so that if we do need to use any kind of restrictive intervention, it's agreed, it's approved, it's safe, it doesn't cause harm, it shouldn't cause pain to anybody. So on an ethical, from an ethical viewpoint there. And Article 5, people's right to liberty and security, and the right not to be deprived of your liberty unless you're suspected of committing a crime or you are judged to lack capacity under the Mental Capacity Act and have a deprivation of liberty safeguard in place. And the last one we're going to look at is the Equality Act from 2010, and this protects people from discrimination generally in the workplace and in wider society. And again, it, like the Care Act, it pulled together lots of different acts of law and put them all into one place and covering a wider range of people. And it applies to public bodies. So as an organisation, it applies to us, and as employees of the organisation, it applies to us, and we need to be taking action to eliminate discrimination and do more towards giving people equal opportunities and trying to foster good relations between different people when carrying out activities. Within the Equality Act, there are 9 protected characteristics: age, gender reassignment, being married or in a civil partnership, being pregnant or on maternity leave, disability, race including colour, nationality, ethnic or national origin, religion or belief, sex and sexual orientation. So as a public body, we need to ensure that what the services we offer and the way we behave with people is consistent and fair, and that no one gets a substandard service or anything is compromised because of any of those 9 protected characteristics. So in summary, what we've been looking at today is around our duty of care, what we need to consider about people's consent and what can be considered to be in their best interests. Use of any unplanned restrictive interventions by staff that haven't been trained may be seen as unlawful, which is why it's important that we follow the training, we have the training, we practice the techniques, we observe you, we assess your competence. And also it's important that if you are supporting someone who may need a restrictive intervention, that you know that person well and you're confident to do that. And gradient support, that comes back to doing the least we have to do for the shortest amount of time, and that's something we'd always need to demonstrate. And again, if we follow people's positive behaviour support plans and guidelines, and you've been on the training and you've learned and practiced the techniques, you should feel confident that what you're doing is okay. And our role and responsibilities around this, protecting everyone from physical harm. So we know that often will include the person, it could be other service users or guests, it could also be staff or members of the public. You mentioned consent, working with positive behaviour support plans and guidelines, being really clear about intervention method you're using, ensure you're confident and competent, and any kind of physical intervention must be recorded, as must chemical and mechanical restraints. And like with everything else, when we've got something set up and in place, it's really important that we monitor it and review it as we go along. And now we have a legislation quiz, which I'm sure you'll be very excited about. But on pages 15 and 16 of the workbook, there's a quiz that just looks at some of the key points of the legislation we've been looking at today. And that's the end of the module. So when you've done that, you can take your workbook next time you have supervision and go through it with your supervisor or line manager, and a week after you booked on the course, you'll receive the quiz, which you can complete and then go on to do module 4, which is health and safety. Yes, I hope it's been relevant to you and it's been okay. Thanks.